Hi dear friends, a very happy new year to all of you, and let's kick off this new year with this presentation on intraosseous root. I think this was a recent question in one of the DNB question papers, and it's a frequently asked question in MD and DCH exams also. So what is intraosseous access and why is it important? The importance here is when the child is going to come to you in shock, it is very difficult to get a peripheral venous access, and central venous access may not be available in resource limited settings. So in that case, intraosseous access is the way to go because it is going to provide a non-collapsible marrow venous plexus access. This is a rapid, safe and reliable route. You can give everything that you give through a peripheral venous system or a central venous line, with the exception of few drugs which I will be discussing further below. What are the instruments used to get a intraosseous access? In resource limited settings, we generally use a Jamshidi needle or a Cook's needle. If you are in a private setup in a very resourced setting, then you can have mechanical drills to insert intraosseous needles. This is an example of a EZIO drill that can put the intraosseous access easily. This system is approved up to 24 hours use and it can be extended up to 48 hours. It's approved for more than 12-year-old age groups. Alright, this is easy and you can determine the distance to which you have to insert your intraosseous needle. This is your standard Jamshidi needle. I think this all of us must have seen in our hospitals. And this is one of the more sophisticated but still a Jamshidi bone marrow needle biopsy. This is I think only for one use, whereas this we reuse after sterilization. This is the beveled edge of the bone marrow needle. This is an example of a biopsy specimen from the bone marrow. This is also a Jamshidi needle. This is a T-handled Jamshidi needle. Alright. So this T-handle makes it more comfortable and better cortical penetration. Plus, if you see in the bevel, you have how to tell? There is the triple crown in the cannula tip. So this can provide better penetration and better cutting edge into the bone marrow. This is again a Jamshidi needle. This is a Illinois Jamshidi needle. Okay, Illinois, ILLINOIS. Okay, so this is a Illinois Jamshidi needle. The advantage here is you can adjust the depth to which you are going to penetrate, especially if you are doing a sternal procedure in adults or in pediatrics where we need precise depth of insertion. So where are you going to insert these needles, be it a Jamshidi Cook's needle or a, automated drill? The most common site in pediatrics is anterior proximal tibia, 1 to 3 centimeter below and medial. Please note that it is medial and not lateral. Okay, it's medial to the tibial tuberosity on the flat surface of tibia. All right. So this, if you insert it here, you end up in the popliteal veins, and the popliteal vein is going to provide an uncollapsible access to rest of the venous system of the body. The other sites that can be used are distal femur, anterior superior iliac spine, distal tibia, and humeral head in older children and adolescents. Since tibial insertion is the most common procedure that we do, I'll just run you through it shortly. Identify the site. Knee should be slightly bent with slight external rotation. Make sure you keep a towel beneath the knee. Alright, because without a towel beneath, if you think you're going to handle it with your hands, it's not that easy. The site tends to move a lot and you will not be able to insert the needle comfortably. So always keep a towel roll beneath the knee for optimal positioning. Cleanse the area thoroughly. Identify the landmark. Then give gentle firm pressure with the needle, your Jamshidi needle, and direct it away from the joint at 90 degrees. Advance with twisting and turning motion. Alright, you will advance with gentle pressure, firm pressure till you feel the giveaway, the loss of resistance. When you feel the loss of resistance, it means that you have entered the marrow. You have to determine the force, and the depth of insertion will be determined by the feeling of loss of resistance. Once you are in this space, remove the stilette from the needle and secure it in place with gauze and tape and make sure that you have actually entered it successfully. So what are the indicators of successful insertion? How are you going to know you are in the marrow space and not anywhere else? Once you remove the needle and try to aspirate, you will see that you are aspirating blood or bone marrow with few bits. You will be able to inject saline into the cannula easily without resistance, and you will not have any swelling of the surrounding structures. If you have the swelling of surrounding structures, it means whatever you are instilling is going into the subcutaneous tissue. You should stop. Alright, and the needle should be able to stand on its own without support. The sudden loss of resistance when you enter the marrow cavity in itself is a good indicator that you have entered the marrow space successfully. So these are the indicators for successful insertion. So you enter, you feel the giveaway, you leave the needle, it stands on its own. When you aspirate, you get blood or bone marrow, and when you inject something, it goes into the venous plexus and not into the surrounding tissue. When are you going to use this intraosseous therapy? It is not that often that you go ahead for intraosseous therapy, right? When immediate access is not achievable in an emergency after 2 attempts, your peripheral venous access you are not able to get, or all attempts at venous access have failed, multiple sites you have tried, you are not able to access, and for 10 minutes you have been trying back to back, you are not able to access, then switch to intraosseous therapy. Don't keep on poking the child. It is not going to help you or the child. What are the contraindications? When are you not supposed to do an intraosseous access? I think the generalized contraindication would be any underlying brittle bone disease, osteopetrosis, because there will be increased risk of fracture wherever you touch. But rest of the contraindication is for a specific site, I would say, and not as a general. So general contraindication would be your osteopetrosis, because the bones are going to be brittle, you are going to end up with fracture. Whereas rest, suppose the tibial site has a fracture or a crush injury, or you are suspecting that there is a disconnection between the bones due to whatever reason without even proven fracture, then you should not do. Why? If you are going to inject fluids, you are going to extravasate and cause compartment syndrome. If there is an infection, that's a no-brainer. You are not going to risk it. You are not going to risk infection. So you will not do at that site. If there is already excessive tissue swelling in the region where you want to do a IO access, then you are not going to be able to identify your anatomical landmarks to insert the needle. So you are not going to do there either. If there has been a previous insertion or attempted insertion within the past 24 hours, if you do like that, there will definitely be a chance of infiltration or extravasation of fluid into the surrounding tissues through the previous puncture site. If you inject it through the new site, you will see that the fluid is coming out of the older site of injection. So don't do that. These are the general contraindications that I can give. What can be given through an intraosseous route? Almost anything can be given. Blood products can be given, fluids can be given, resuscitation drugs can be given, your vasopressor, catecholamine infusions can be given, medications, antibiotics can be given. You can even give it as a bolus, you can use it as a route for bolus therapy. You can attach the fluids to a rapid infuser pump, or you can manually push, or you can attach a BP cuff to your bottles, your fluid bottles inflated to 300 millimeter of mercury, so that it acts like a rapid infuser. What cannot be given? As I said initially, there are few drugs like tetracycline, vancomycin, phenytoin, chloramphenicol, tobramycin. These should not be given because the peak concentrations reached in the serum are actually lower than what is desirable and lower than what is achieved through a peripheral or a central venous access. So we generally do not give these medications through intraosseous route. What are they? Tetracycline, vancomycin, phenytoin, chloramphenicol and tobramycin. Complications. So what complications can you expect when you are inserting an IO needle? Less than 1% complications have been reported if you do it properly, that is. There can be a fracture, there can be compartment syndrome, there can be extravasation or infiltration of drugs, and there can be a risk of osteomyelitis if it is not a sterile procedure. What is this extravasation and infiltration? Are the terms interchangeable? It's actually no. When you say infiltration, it's a non-irritant drug. When you say extravasation, it is a irritant or a vesicant drug. Both are going to go into the subcutaneous tissue. They are not going to stay in the venous compartment. When you say infiltration, it means it's a non-irritant thing that is going out into the subcutaneous tissue. When you say extravasation, it's a irritant or a vesicant that is going to cause a tissue erythema, redness, blackness and all that. How long can you keep a IO needle or a IO access? Ideal duration is less than 24 hours, but if push comes to shove, maximum 48 hours and definitely not beyond that. It's a temporary means. You need to replace the fluids that the child has lost. Once the fluids are replaced, the venous peripheral or a central venous system is going to be easily accessible to you. So replace your IO with a peripheral needle. One important thing that I would tell is always secure an access before removing the IO needle. Don't remove the IO needle and then try for an access and then don't end up not getting an access. So this is a very important point. The advantages are it's got a fast accessibility. The onset of action is comparable to that of a central venous access, not even a peripheral venous, it's a central venous access. It's a non-collapsible vascular access, even in shock. This is important for us, no, because in shock, your peripheral venous system are not going to be accessible because they are collapsed, whereas your marrow cavity is going to be a non-collapsible access. And the blood taken from the marrow can be used for blood biochemistries, blood gas, grouping, cross-matching. Basically, whatever you need in an emergency, the blood can be used for analysis. These are my references. You can go ahead and read Advanced Pediatric Life Support or Rogers Handbook. These are the references from which I have taken most of the topics from. So thank you guys for listening to me patiently. This is an important question for your practice in ICU as well as your theory exams and your instruments station during your practical exams. Thank you. All the best. Happy New Year once again. Let's all hope to have a happy, prosperous, productive, peaceful New Year ahead. Bye bye.